So when we're talking about this menstrual timeline, we're talking about 3 cycles happening simultaneously, but they're controlling each other. And so we said we had the hypothalamic pituitary part, then we had the ovarian part, and then we had the uterine part. So when we look at that, I want to remind you guys what the hypothalamic pituitary, what the whole axis looks like when you include all these things together, because then you'll be able to kind of visually look back and remember it. With the hypothalamus released GnRH that had to be pulses that went to the pituitary, which released early on follicle stimulating hormone and then later on luteinizing hormone. Those both would go to the ovaries. Those would cause release of progesterone, estrogen. So it's causing a release of hormones. That was hormone A, hormone B, hormone C's. But it was also causing the follicle maturation and ovulation. So that FSH and LH was doing both. It's causing the ovaries to do something, but it's also then saying, okay, also make estrogen and progesterone. And then the progesterone and the estrogen go down to the uterus, to the endometrium. And that's where the endometrial lining comes in. When we start the month, we always call day 0 is the first day of the last period. And so when bleeding starts, that's called day 0. That first part is when the eggs start to mature. They're called follicles, not the egg itself, but they're called follicles is what they're maturing in. That's going to be called the follicular phase. The menstrual period happens right here, usually about 14 days after the last menstrual period began. A day or two off. If people have menstrual cycle disorders, it might be off more than that, but it's actually pretty consistent otherwise. Day 14, ovulation day. And then after that, after the egg is released, we're going to have the luteal phase because the ovarian follicles are making something called the lutein. And we'll talk about that. But those 2 phases are named after what the ovarian follicles are doing. They're follicular, they're luteal. That's going to be the last or the second 14 days. And then the menses is going to start again. The reason that they call day 0 the first day of the last period is because that's a date women know. Like you can't ask women, what's the day you ovulated? Because most women, unless they're tracking it, aren't going to know what that day is. And so trying to track a cycle by that doesn't make sense. So that follicular phase and the luteal phase, this is right here, the GnRH released from the hypothalamus onto the pituitary, where we're releasing FSH and LH. So during the menstrual cycle, the first half of the month, what we're going to see is GnRH. This is the frequency, not the amount released. So you start at a low frequency and it goes upward. The frequency increases. At the beginning of the month is moderate. That's telling your pituitary to make FSH. So a moderate pulse frequency says, hey, make FSH. When that pulse frequency gets higher, that tells the pituitary to switch. And it says, no, now make LH. LH is going to peak, and then your GnRH's frequency is going to drop off very, very significantly. And when that drops off, that's telling you to make less FSH and LH. Like, don't worry about it. We don't need you guys anymore for the rest of the month. So that GnRH from the hypothalamus is controlling the switch from FSH to LH. FSH stood for follicle stimulating hormone, and LH stood for luteinizing hormone. Remember what those are doing, the LH and the FSH, is their whole role is to go to the ovary. So here we have the follicle. This is all happening in the ovary itself. When you start out, you've got women have all the, they say, oh, you have all the eggs that you're going to have when you're born, but they're not mature. They're not like eggs that can be ovulated. They're like proto eggs and they're in follicles, which really just means the tissue that's surrounding the egg. And so you're starting out with immature eggs. Those immature eggs are not ready for ovulation. So what follicle stimulating hormone is it's telling the follicles to mature and to mature the egg. So that name of it, if you forget which is first, which is second, is follicle stimulating hormone is first because it's stimulating the follicles to mature. Once the follicles have had 14 days to mature, that's when you switch over your GnRH and you switch over the FSH to LH. So now here you have a LH bump. So here was FSH, and now you switch over and you have an LH bump. Luteinizing hormone is the signal to the follicle to release the egg. That is what says ovulate. Follicles and eggs mature because of FSH. And then after 14 days, that switches and it switches over to LH. And that is what tells the follicles to release the egg. So now you've got the egg released. That's great. Now you're going to have that egg out there and it can be fertilized. What's also happening here is, well, let me just go through the fertilization part, this part, and then we'll talk about estrogens and progesterone. So you have the ovulation occur here. The egg's gone now. It's floating out there. The follicle is going to do something. It's going to die. It's not needed anymore. Now the egg has been released. Follicle's not necessary. It actually turns yellow, which is why they call it the corpus luteum. It's the yellow corpse. And remember, it's the dead follicle. So you got the egg ovulated and now the follicle dies off. That was one thing the ovary was doing. But remember, the ovary had to do two things. It had to set things up to mature the egg and to ovulate, but it also had to make progesterone and estrogen. So that's simultaneously as you're seeing the FSH and LH causing maturation and ovulation, you're seeing the ovaries at the beginning of the month creating estrogens. And so estrogen goes up through the month. It peaks at the same time you have ovulation, and then it goes down. I don't care about all the little bumps. I'm saying it goes up during the first half, and then it peaks at ovulation and goes down. Progesterones do the opposite. They're low in the first half, and then they raise in the second half, and then they plummet down at the very end. This is going to make sense because the role of the estrogens in your uterus, because estrogens do things all over the place, right? But in the uterus, the role of the estrogens is going to be to build the endometrial lining. So that's why estrogens are increasing in that first half of the month. They're saying, build this lining, build this lining. Get ready, because when you ovulate, we want a really nice, thick, and nutrient-rich and oxygenated environment if there's fertilization for that fertilized egg to implant it. So that whole first half of the month's goal in the uterus is to build that lining. Now you have ovulation, and the lining of the uterus is still going to stay there because it's waiting for fertilization. It's like you're not going to fertilize the moment of ovulation. So it's going to stay doing its thing for a little while. Okay, so you had that estrogen increase. That was causing the building of the endometrial lining. Then you had ovulation. The lining stuck around for a little while because it wants to make sure that it's there if there's a fertilized egg that needs to implant. But if there isn't a fertilized egg to implant, that estrogen is going to now go down because you don't need to keep building the endometrial lining if there is no pregnancy. Instead, if there's no pregnancy, you want to shed the endometrial lining you have so that you can build a new one the next month. And so that's then why you switch from estrogen to progesterone, is progesterone doesn't build, it retains. So you're no longer building lining, you're just holding on to it. You don't want to make more of it. You're just kind of keeping it there just in case there is fertilization. Now you reach the point where your body's like, okay, no fertilization occurred, so I can get rid of this lining. Progesterone's role, again, was to retain the endometrium. Once it decides, okay, there's no fertilization, there's no implantation, we can get rid of this endometrium. The way you do it is by dropping that progesterone. So the progesterone had that sudden, that pretty precipitous drop off. When you have the hormone that retains it, and now you get rid of the hormone that retains it, now you're not retaining anymore. And that's what initiates the shedding of the endometrium. This is going to drop off a few days before the menses begins because you have its hormones, right? They may take a little while to do what they're doing. And so the progesterone drops off, starts to tell the endometrium, okay, you're going to go. And then because of the progesterone drop, we come back here to day 0 where the menstrual period begins. If I want to summarize this, I'm going to say the hypothalamic pituitary timeline is controlling everything because the GnRH and FSH are telling the ovary what to do. The ovary is responding to that by telling the follicles how to mature and when to ovulate. And the ovaries are also responding to it. Are we going to make estrogen or are we going to make progesterone? Now, the ovulation and all that, the ovary did that. That was a final product of what we wanted the ovary to do. But now we're going to have one more step because the estrogens and progesterone are going to do their thing. And so that final step that the estrogens are doing is causing the growth of the endometrium, and the progesterone is retaining the endometrium. The progesterone drop tells the endometrium to drop, which comes over and starts the first day of the menstrual period. This is a complex cycle, but to me, you have to think of it as 3 different things happening. Each of them are controlling the other. So you're starting with the hypothalamic pituitary, you're going to the ovarian, and then you're going to the uterine. That's like key. Estrogen's going to build, progesterone's going to maintain. And so progesterone goes down, shedding happens. In the case of a pregnancy, these guys don't die. So here, those guys are dying. In the pregnancy, these guys are told to stay alive. And so what they're going to do is they're going to keep progesterone going. What happens if your progesterone doesn't drop? You retain the endometrium. The endometrium doesn't shed. So as long as the corpus luteum now takes over and says, "Oop, I got a signal that you're pregnant, I'm going to keep progesterone going," that's going to keep you from having a menstrual period. And that's going to let you retain that pregnancy. So just saying it again, hypothalamus has a release of GnRH, has to pulse. Pituitary then releases the FSH, and that causes the ovarian follicles to mature. And it also causes them to release estrogen. That estrogen is what comes back and tells the hypothalamus to now change the GnRH pulse frequency. That then tells the pituitary to change to LH. That LH comes down and then tells the ovary to cause ovulation. And it's also telling it to kind of switch over to progesterone. So I just wanted to kind of list it a different way so that you can kind of see it as here's the first step, here's the second step. Okay. So first question, if you create extra physiologically high levels of estrogen, what's going to happen to your FSH? So high estrogen, going to reduce FSH, right? You can look at that on this slide, or you can, to me, it's easier for me to answer that question if I think about it as that diagram of the hypothalamus pituitary and then the negative feedback coming back up. So you got it. It's going to decrease FSH. What is that decrease in FSH going to do to follicle development? Decrease, exactly. So what happens then if you block progesterone receptors at day 21? What is your progesterone? What's its big role here? Maintain, right, is to retain. So normally the body starts to reduce progesterone here, right? That's going to cause shedding. But what if you used an antagonist and you blocked progesterone receptors? That's going to just initiate the shedding. So that would cause a period to begin earlier or shedding to occur at that point. If you allowed FSH to release but blocked LH, what's going to happen in your follicles? They're going to develop. Yeah. Are they going to? Yeah. So they're going to develop. That's fine. But what aren't they going to do? Ovulate. Right. So they're not going to ovulate. What instead of letting progesterone drop, what if you gave a pill that kept progesterone high? You'd keep retaining, right? And so would you have a menstrual period? No. If progesterone stayed high consistently, you wouldn't have a menstrual period. This may seem like a silly question, but it is not. We're going to go to have you guys do a little poll daddy here. And what is your definition of pregnancy? There's way different answers to this. And so some people are first day of the last period, some are implantation, fertilization, first heartbeat. That's what you're going to see is everybody has a different definition. So when you're talking to people about pregnancy, you can't just assume that they mean the same thing you mean. This definitely matters, and you will be surprised at how these changes in definition are used differently. Medically, pregnancy occurs when a fertilized egg implants, because not all fertilized eggs are going to implant. And so what they can measure is if you know it implants, that's when pregnancy starts. Religiously, it depends, right? Everybody's going to have a completely different definition of it. Legally, because they're using day 0 as the first day of the last period, they count pregnancy from day 0. So that means legally pregnancy begins 14 days before ovulation and 15, 16 days before fertilization. So obviously, physiologically, that's ridiculous. You can't have a pregnancy begin before you even ovulate, but that's legally how it's counted. And so when you look at anything that's referring to like 6 weeks of pregnancy for laws, they're actually talking about like week 1 is pre-ovulation, week 2 is pre-ovulation, then you get ovulation, then you get fertilization. The end of week 4 would be the first missed period. And so then you've got 2 more weeks after that. I was surprised the first time I saw this, that medical and legal definitions were very different. I wasn't surprised that religious personal definitions are different because they are. But the difference between the legal and medical really kind of surprised me. So we're going to talk about pregnancy itself. I could talk about fertilization, but honestly, sometimes we just need Dr. Mike. So this is a diagram of pregnancy. Here's the duration of pregnancy by weeks. And here's just the amount of the hormones. So here we have that HCG or HCG. We have progesterone and we have estrogen. And so immediately after ovulation, the corpus luteum is making a small amount of estrogen, but really what the corpus luteum is trying to do is keep making progesterone so that you don't shed that uterine lining. After fertilization and implantation, the embryo takes over and it makes the HCG, and that's going to tell the corpus luteum to stay alive, and it's going to tell it to keep making a small amount of estrogen and keep making the progesterone so the endometrial lining doesn't go. Later, the placenta, when it's made, takes over the progesterone and estrogen production, and that placenta is now going to cause progesterone and estrogen to both rise. So what keeps you from ovulating again while you're pregnant? It's that negative feedback cycle in that now you have a lot of estrogen and you have a lot of progesterone that's being made by the placenta. So now you're pregnant, you've got a lot of estrogen and progesterone. There's enough estrogen and progesterone here for it to go back up to the hypothalamus and pituitary and be like, we don't need FSH and LH anymore, we're already pregnant. So no more ovulation. So that progesterone during pregnancy, at the very beginning, the progesterone is just keeping the uterine lining there. Then it's keeping everything good, but it's also helping the pregnancy continue and the development continue. Progesterone itself is still necessary in order to maintain the fetus. All right? So, and you know the answer. What's measured in OTC pregnancy test? Say it with Australian accent. HCG.